The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome back to the Success in Practice podcast. Today I'm joined by Dr. Keran Sundaraj. Dr. Sundaraj attended medical school at Monash University in Melbourne, returning home to complete his orthopaedics training in New South Wales. He's a knee, hip and trauma surgeon with subspecialist training in complex knee surgery. He completed a fellowship with world-renowned surgeon Professor Leo Pinczewski, a pioneer in the field of ACL surgery. Since that time, he has joined Professor Pinczewski in partnership. Dr. Sundaraj completed a Master of Science in Trauma Surgery at the University of London. He has published in numerous peer-reviewed journals and has been invited to present at international conferences. Dr. Sundaraj is the Director of Training for Orthopaedic Registrars at Liverpool Hospital, and he has a keen interest in teaching and is an adjunct senior clinical lecturer at the University of Notre Dame. He is a partner at the world-renowned North Sydney Orthopaedic and Sports Medicine Centre and is the current managing partner. He's a member of the North Sydney Orthopaedic Research Group as well. Okay, so today, Keran and I have been cross-referring now for a little while, almost 3 years now, I think. And I got to know Keran professionally through Professor Pinczewski, whom we've been working with since 2010. As one of his preferred practitioners in the areas that we treat. And so when it comes to treatment of knee pathologies and pre- and post-surgical rehabilitation, Professor Pinczewski and Keran refer to us, if patients are out that way. So that's been great for us, and we've built a lovely relationship there with Keran. And so before I get started, I want to just mention a small story. When I was, I think back in 2010, when we began working a bit closer with Professor Pinczewski, I went out and did a bit of surgical observation with him, and we got to see ACL reconstructions and arthroscopes, and I saw a tibial osteotomy and a knee replacement, and I got bits of knee flying around everywhere and had to duck. So that was an interesting time we spent, and going out there, it was like my first experience. And so I went to see Dr. Pinczewski's team over at the clinic there at the Mater Hospital. I bought with me some bottles of wine and some gifts and so forth for his staff. And so I handed them to Dr. Pinczewski, and he looked me straight in the eye. He said, "Sammy," he goes, "Look, I know we're both wogs, but and this is lovely that you've given us all these gifts, but we refer to you because you're good at what you do, and I'm sure you refer to us because we're good at what we do, and that's the reason why we're referring." And I looked at him, I said, "Yeah, that is the reason why we're referring." And I think I had a similar conversation with Keran when he sent over a nice gift for our clinic this year. And the point I want to make is that although I got to know Keran through Leo, the rehabilitation I've done on his surgeries have been of the highest standard that I've seen being around Leo and being around other surgeons. So we're quite privileged that we get to rehabilitate those knees. They are much easier. I always describe it as like a hot knife through butter. Rehabilitation is so much easier after both Dr. Pinczewski and Dr. Sundaraj have done surgeries. So welcome to the podcast, Keran. Glad to have you here, mate. And hopefully we get to learn a lot from you tonight.
Thanks for having me, Sammy. That's a very, very kind introduction to things, but yeah, a very apt, I think, description of Leo, and also that generosity as well, and very kind words about rehabbing our patients. That's a two-way street, right? That relationship between surgeon and allied health practitioner, really important. Absolutely.
Yeah, well, we appreciate what you do, mate. It makes our job a lot easier. Let's get into it, and And tonight I want to discuss obviously knees and also some trauma surgery. But before I do that, I want to get a bit about your backstory. I want to understand where you've come from, and tell us about you growing up and going to university and early practice, and then how that led you to where you are now. Give us some background about you, Keran.
So I grew up in Sydney. I grew up in Gladesville. I went to school locally. I've got a couple of older brothers and sisters. I come from a medical family. My dad was a pain specialist. Mum was his practice manager. So I kind of grew up in a very medical household where that was the topic of conversation. I never wanted to do medicine, so I applied for it when I was 17, leaving high school, and I thankfully got in. So I moved away to Melbourne at that point, and I actually really disliked it for the first couple of years. You're a teenager, right? How do you know what you want to do? So
no, you don't.
Yeah, got no idea. So I took a year off, and I came back to medical school actually far more interested and really engaged in it again. I always knew.
What happened in that year off, mate? What did you do?
I went and managed a clothes store in Paddington, actually, for a short period of time. It taught me lots at that time. So I had two jobs, actually. One was I worked in a mailroom, which was a really interesting experience. I think I had a pretty sheltered upbringing. I went to a private school, and I moved in demographics that are not necessarily normal, I think. So my understanding of general society as a teenager was pretty limited. I moved away to college, and that was a big exposure. The other sex, people from different cultural backgrounds, different socioeconomic backgrounds, doing different courses, having different outlooks on life. And so that was eye-opening in itself. But then certainly taking time off, going and working in a mailroom, is a unique experience. There's just a different set of people that you don't always get exposed to. I realised that that's not a job for me necessarily, so I went. And
you're at the bottom of the food chain there in the mailroom.
Mate, there was no windows, and there was some odd people in there. Right? Some of them were there for 20 years. They loved that job. Some of them hated it, but there was a routine to it, and it didn't take long to master it, and that's the goal for some people, and that's okay. But it wasn't for me. Yeah. So, I took up this job working in retail, and it taught me heaps. Right, talking to people that come in off the street, it really taught me to engage with people and to talk to them on their level, to start to understand them. Sales it's often part of many different professions, right? I don't try and sell treatments to patients, but I think the way that you can communicate with people, there's often a bit of sales in that, right? If you're trying to get your point across, you're often trying to sell an idea that they can select from, I think, when it comes to medical practice. But you have to get that point across. So that's kind of what I learnt. I also realised that there was a ceiling to the retail part of it, and it wasn't, like, as fun as it was to pick up on those skills, that wasn't me forever. So I went back to med school. And in going back, I think there was some perspective finally. So I had learnt a bit about the world, and where I fit into it, where other people fit into it, and part of the medicine part of it started to make sense. The problem with the first 2 years of medicine is that it's all theory. You sit there, you're in a classroom, and again you're a teenager, and you're having to sit through lectures and stuff that has no real clinical, real-world application at that time. So I needed some new perspective. So the year that I went back was into clinical practice, or placements, as you call them. So going through different rotations in the hospital, and you're following different teams. Again, not all of it really made sense at the time, but I got to do some surgical rotations that they were fun. Yeah. I think my first one was in a neurosurgical department. It was like a 12-hour operation. I did fall asleep for part of it in the corner. The neurosurgeon was talking to me at the start. I woke up and he was still talking to me like an hour later. So there was bits of it that were, still like uni, I guess. In some
were you able to kind of understand the gravity of it? Like at that time, you were probably like 20 or 21. Did you kind of get where you were going to be? Like, if you keep following this pathway, you're going to be the person on that end of the knife rather than the person sitting in the corner watching. Did that kind of make itself known to you?
I don't think so. So some of the elements, because part of it as well is that as a medical student, you come in for snapshots. You see a patient for a short period of time and you listen to their story, but you might not see where they progress to. And I think that's important when you start out. Like, you need to have these little snippets of clinical perspective. What can be really shocking is when you see the whole journey start to finish, because some of it can be really traumatic, right? If I think back to the next steps, right, and maybe I'm jumping ahead a little bit here, when I start to interact with patients as a doctor, as a junior doctor, and I get to experience them from the start to the finish, but particularly when it's in a really short period of time, like in a trauma patient, and there's not a good outcome, that kind of sticks with you, right? Some of those experiences are really traumatic. They can be good experiences because they develop you, but you have to be ready for those experiences as well. And I think as a medical student, you're building upon it, and then you start to put it more and more into practice as you get more senior. But it's hard to understand the gravity of situations without knowing the bigger perspective.
Right. Okay, so tell us about your journey through tertiary education and what made you take the particular pathway that you took.
Yeah, so I kind of wanted to do surgery when I finished medical school. I had dreams of being a plastic surgeon with my best mate, who is now a plastic surgeon actually. We probably watched too much Nip Tuck, and then I realised what plastic surgery actually was, and it wasn't like Nip Tuck at all. But I also realised that's also not the medicine that I want to be involved with. When I started as a junior doctor, so you start as an intern and you rotate through medical fields and surgical field and emergency, a few different things, right? So you're getting a bit of a mixed bag, learning different stuff. And my second rotation was in orthopaedics, and I kind of just fell in love with it. Kind of made sense for me straight away. Like, I went, this is surgery, and it's good surgery. I like this surgery. And it was surgery that was improving patients' lives. Like, there's a lot of surgery that we do that is life-saving, very heroic stuff, blockbuster sort of stuff. But it's about, for me, it's more about the outcomes. You can do great surgery, but if you got a crappy outcome, it's probably not much point. And I mean, an example, and they're not always like this, right? But like, brain tumours or bleeds on the brain, right? So yeah, you can save someone's life. A lot of people have good outcomes. Some of them will have not so great outcomes, and some of those things, I wanted to bat an average that was better than other specialties. Basically, I want better outcomes, and orthopaedics, I think, delivers that for us.
Yeah, right. Okay, so you based, I guess, your decision into orthopaedics on the outcomes that you saw you could get for patients.
That's only one part.
Sorry?
That's one part. I think that's one part of it. I think the other part is also the MO of the specialty, right? There's a problem. It's not really a diagnostic dilemma. Sometimes it is. It's not really. And you have a bunch of treatment strategies and solutions, and you apply those strategies, and you can see outcomes reasonably quickly, right? So in surgery, you see an outcome pretty quickly. You institute rehab or that next treatment pathway, and you see an outcome again. So it's very tangible in that sense.
Yeah, right. Okay. No, I understand that. And I think, like you could see the outcome post-surgery, but you can also see the better outcomes as rehabilitation comes into play. And then, if you see somebody a year down the track, it's a nice experience for you, rather than just seeing somebody post-trauma where you're not going to see them, you see them for that first week and then see you later. You probably wouldn't see them again in your life. So I understand that. Then tell us, how did you come about? I think you did a fellowship with Leo. Tell us about that. How did you come about that, and how did that partnership, I guess, grow?
So as a trainee, when you get onto the orthopaedics training program, you go to different hospitals every 6 months. One of those hospitals I went to was Amada, and I was Leo's registrar. Quite some time ago now. I'd have to count back now. But at the time, he talked to me about coming back, and he said, you should come back and do my fellowship, and one day I might want to retire, and obviously want to pass on the practice. And at the time...
Why do you think he asked that of you? Because I've spoken to Leo, and he's not always enamoured with all the fellows that come through.
I think it's a combination of factors, right? I think I think there's, I think you have to meet the bar, but I think there's plenty of guys that meet the bar. And then there's also, that's my side, and there's also his side, right? The time and place for him as well. So one aspect is,
he's got to be ready.
Yeah. So there's one aspect, like the person that you passing your practice on to has to be good enough, and you have to get along with them, and you have to have the same ethos and mentality and work ethic and all that kind of stuff. That's really important, right? And then there's also the other person who's passing it on. Yeah, they have to go, I'm ready to do this, right? I'm ready to move to the next stages of my career.
Right.
So, there's 100 other orthopaedic surgeons that can be in my place as well, right? Could be a different person.
I'll beg to differ with you on that one, but we'll leave that for another conversation. I think, look, from my experience as a I guess a rehabilitation provider, an osteopath, and somebody who sees people post-surgery, I could honestly count the recommendations I would make for a knee surgeon on one hand in Sydney.
Can I ask you a question, Sammy? Then on that point, then you mentioned that before about like hot knife through butter, right? So what do you see that's, because I don't get to see it, right? I don't get to see other surgeons immediate post-op work that often. It's pretty uncommon. I see complications, but we all have them, right? Mm-hmm. So what do you see that's different?
Okay, so the first one is pain, right? Mm-hmm. They're in significantly less pain and significantly less swelling, which means you haven't gone around and fart-assed around in there during surgery. You're very, to me, it would say that you've been very clean with the drilling, the cutting, the whatever it is you've done in there. You've been very clean. You haven't had to do it 10 times. You've probably measured 3 times and cut once, as the saying goes. So that's the first thing. So this pain and the swelling is significantly less. Now, mate, I'm an osteopath. I've got my hands. One of my skills is to put my hands on people, and I get to palpate their tissues. And I can feel tissues, and I feel what a healthy tissue feels like, and I feel what a really dysfunctional tissue feels like, and I can make a difference. And when I put my hands on a surgery that Leo's done and you've done, those tissues are closer to health than what anyone else has ever given me. So that's the first thing. The second thing is movement, right? Well, the third thing is, movement. So I could get your patients into extension a hell of a lot quicker. Those first 4 weeks of trying to get knee extension, it's just easier, much easier. I have to use less force, less articulation. I don't even have to engage the barrier all that much, and it just as long as I just give it a nudge along there, it goes there by itself. It wants to go there. So which means that you just haven't hammered those tissues to a point where I really need to work hard at trying to get normal function back into them. Now, one of the things that I've read in I think the statement that got released by the North Sydney group there is that there's a huge emphasis on respecting the tissues and where they are in a stage of healing, and that really resonates with me. And I think that's a big part of it. Is you guys really you respect the tissue, and you don't do what's unnecessary, and you're good enough not to have to. And so I don't know if that's enough for you, but clearly in the first 4 weeks to 6 weeks of my rehabilitation, I'm finding less swelling, less pain, easier movement, easier return to getting them to a point where I can get them on a bike, under a bar, lifting weights, all that kind of stuff. It's just quick. It's a quicker process. You guys you give me about 3 weeks, 3 or 4 weeks ahead of the rest, right? So I can comfortably then say to a patient who's saying to me, I'm going to need 9 months. No, not really. If you've been under Keran's hands or Leo's, you'll be back in 6. Back in 6, or even if you really want to push, you'll be back in 5, depending on obviously the state of the patient. But that's my answer to that question for you.
Yeah, that's an interesting perspective, because we don't always get to hear or see it necessarily as acutely as that. So I think that's probably part of the picture. Yeah, I hope it is. There's probably factors that go into that as well. The patients, choosing the right patients as well.
Yeah.
Choosing the right patients for the right process. Like you wouldn't choose a patient who couldn't go through an ACL rehab or who's not going to do it very well. You wouldn't necessarily put them through that pathway, right, or surgical pathway. Yeah. And then there's the perioperative pain management stuff, which I think is really important. and the checking in with them as well. So being with my anaesthetist and the way we do local anaesthetic infiltrate, we got patients walking out of hospital. We got their swelling down because surgeries are short. Yeah, that's a technical thing, right? But they're going home with good pain control, with good anti-inflammatories, and they're getting the phone calls from Vivian, our clinical assistant, within a couple of days to check on how they're going, and that gets flagged with me if there is a problem. All those little things. I don't like other people managing those pain problems. I don't want them managing my wounds. They're my wounds, they're my problems, right? So all those things, they've got to come back to me, I think. So I think the surgery part's one aspect of it, but Leo's taught me there's this whole other picture to it, right? The input that you have into that surgery and the output that you have is super important. And they're just as important as each other. So yeah, definitely.
So that's been our feedback. Look, me being an osteopath, and I don't know if there are any other osteopaths on that list of preferred practitioners that yourself and Leo have, we have a very keen kind of sense of touch, and it's still part of our education, it's still part of our treatment. I think now, current physiotherapy education, I don't think they touch people anymore. I think it's all very exercise-based, and so we're still very manual in terms of manual therapy. So from a tactile point of view, the tissues just feel better. They just feel like regular tissues. They don't feel, a tissue that's been, post-surgically, what's the word I'm looking for? Aspirated with swelling. It feels boggy. It feels like Play-Doh to touch. You put your finger on it and it doesn't bounce back. But the tissues post-operative with yourself and with Leo, they just feel more elastic. Okay, and that's just that's an objective finding from me as a therapist. Now, can I correlate that from an evidence point of view? That'll be hard to do, but I guess the more feedback you get on that. But the thing is, I've rehabilitated, probably I'd say 15 to 20 different surgeons across Sydney, and you guys are like Maradona and Messi. You're far ahead of the rest. That's the gap. I'm not making any. I'm not because I'm talking, but that's the gap.
It's probably the same similar age gap as well, though, isn't it?
Yeah, similar age gap too. That's right. I don't think Leo was doing what Maradona was doing, but anyway. But yeah, that's for me. That's the quality gap, right? That's the quality gap. But look, I'll move on to now that we've kind of discussed that. It's a good segue into speaking about some knee issues. And so let me go through this, and this is important for the listeners because it's important to understand. I want to first discuss the four main, the knee procedures that are out there: arthroscopes, ACL reconstructions, high tibial osteotomies, and total knee replacements. So we'll start off with arthroscopes, and arthroscopes are basically, what's commonly known as the clean out of the knee, of the cartilage, whether it be articular or meniscal cartilage. It's not really, a go-to surgery anymore like it used to be. Tell us a bit about that and why that's the case now, that, it's not a highly recommended thing like they used to be back in the day.
Yeah, so arthroscopy is a keyhole surgery to look inside the knee. That's what an arthroscope is. And then it can have add-ons to it, right? Chondroplasty, like shaving off cartilage, or a meniscectomy, cleaning up meniscus, or meniscal repairs, things like that. The scrape and clean out, as it was once described, footy players having an injury in the meniscus tear, they probably arise from an era prior to the MRI scan. A lot of diagnostic work is done based on your history and your examination. The MRI scan only confirms what you already know. And that comes from a historical perspective, because we didn't always have MRI scans, and they weren't as freely available as what they are today. So clinicians had to be good at diagnosing. And then when you thought someone had a tear, you went in and you did something about it, right? And sometimes you're right, sometimes you're wrong. But it meant that people were constantly getting scrape and clean outs. What we do know now, from doing, so many of them for so many years, and my predecessors, I won't say are guilty of it. It was just common practice. But prior to there being good evidence for it, that's just what was accepted. There are several randomised control trials now where people will literally have sham surgery. So you have someone with mild arthritis and say degenerate meniscus tear, and you decide to put them into a study, and they can have surgery or they can have a sham surgery. So that's where they literally make a cut, they play music, they play shaver blades, like as if they're doing the operation, they pump fluid around, like they do all those bits, even the patient's anaesthetise. And then we see what their outcomes are. Some of them, the other group, obviously go on to have the scrape and clean out element of it. People end up in the same spot at the end of 12 months, right? So 30% of people will just get better. They'll feel better automatically from that because there's a 30% placebo effect. It doesn't last forever, though. And there's a small percentage of people that will get worse because they have a complication from surgery. Surgery's serious. It doesn't matter how small it is, right? You can have anesthetic complications. You can get infections. You can damage nerves and vessels. You can get chronic pain issues. You can die from an anesthetic, right? So we don't take those decisions lightly anymore. So that means that we have to readjust and recalibrate. What are we trying to achieve for people? If we're putting them through an operation that doesn't really have much benefit, then we shouldn't be doing it. And that's so the people who have degenerative disease in their knee, so they're already starting to get arthritis, they've got a degenerative tear that fits in that arthritic pattern, they're not the people that should get an arthroscopy. They still might ask for it, and there's still practitioners out there that might do it, but realistically, they're not going to get better. They're not going to get any better from doing that operation. What they're better off doing is all the conservative measures. Weight loss strategies, getting their quads firing, doing targeted rehab programs, looking at their quads, their hammies, their core,
getting stronger
stuff. That's what matters. That's what's going to make a difference in the longevity of their knee.
Well, that generally makes a difference in most arthritic problems, not just knee issues. Yeah. Okay. All right. Well, thanks for explaining that. Let's. I'll move on to, I guess, ACL reconstruction. Yep. Sorry. Go ahead.
Qualify that though, Sammy, because then there's the younger person, right, who's had an acute injury. An acute injury is different to the chronic degenerative issue. So that's what I talked about, chronic degenerative stuff. The acute tear, the young person, they've had a footy injury, or the roofer that was twisting while in a flex position, they've got a backward handle tear of the meniscus. Different story, right? They're getting treated potentially with surgery if it's appropriate. Yeah.
So let me ask you, I guess, a question on that. Bucket handle tear. You go in, you have a look at it, and you go, geez, I've got to get rid of 2/3 of this meniscus. Where does this leave them moving into the future?
Yeah, so the first decision we have to make is it repairable? Right, so the meniscus in itself does not, it's a C-shaped structure, right? At the edges of it has a blood supply, but not in the center point where it gets its nutrition from the joint itself. And we divide into 3 zones: the red zone, the red-white zone, and the white zone, right? And the further in the knee you get, the less likely it is to repair. To heal. Like, we can technically repair it, but it's probably not going to heal. So chronicity, like how acute is it? Is it days, weeks, is it months? Which zone is it in? And what kind of configuration the tear is? And then probably there's the patient factors, right? How old they are, what they want to get back to, things like that. So in the young person, I'll try and always repair if I think it's going to heal. If I think it might heal in a younger person, I might be willing to give it more of a go, because we want to try and save their meniscus. What's the downside of losing a meniscus? Yeah, you lose the shock absorbing effect of that cartilage, that offloading effect. So there is more forces that go across the cartilage surfaces then. That's going to increase your risk of arthritis later in the future.
The articular cartilage.
The articular cartilage, yes, that is. Yeah.
Yeah. Okay. What about? Are there any? I guess we hear it all the time on the news, and any kind of new technologies. They talk about these plastic or these kind of synthetic cartilages, meniscus, that they can insert into the knee. Is this something that's kind of, on the radars? Are people doing things about that, or is it just something that, because knee replacements are so good these days, are they just not worrying about it anymore? What's going on there?
Yeah, I'll come back to that comment about knee replacements so good these days. I wouldn't necessarily agree with that, but we'll come back to that, I guess. But there's plenty of things that have been tried, right? There's synthetic things. There's doing transplants, take it from one person to another, trying to insert chondrocytes and mash it up into different forms, and it's evolving technology, right? None of it has really been out there outstanding with results. And part of the problem is that the best level of evidence you can have is a randomized control trial, but some of these things are impossible to put through that kind of clinical judgment. So you might have cohorts of patients that you follow for a period of time, but you don't really know if what you've done has made a great difference to them, because you don't know how they would have been otherwise if you didn't do anything to them. So it can be a really difficult thing to study, because now you're starting to whittle down the pool of patients, because you're asking looking for really specific things. The young person that's lost a meniscus, for example, and what happens to them over a 20 or 30 period. They're hard things to study, they're hard things to find patients for. And so our knowledge on what works from a technology point of view, lots of things are really expensive, really jazzed up, they look kind of cool. Americans love to take on lots of fancy technology like that, and it's marketed heavily. Do I think any of it works? Probably not. No.
Okay. And I guess you'd put all the injections and the, peptides and things like that in that particular category. I mean, we hear a lot about it, and patients always ask me. I mean, they probably speak to me about it because I'm the first line, and they'll come in and they say, "Oh, I heard about this injection and BP something or other, and can I do that or whatever?" There's nothing out there, I think, that it's a silver bullet.
So I break that into there's old mate from the western suburbs that's come in asking me about testosterone and peptides and supplements you can take. There's that exogenous kind of, what are they going to take? And I just go, nonsense, right? Because they've all done their research on Google, right? And so they're all an expert. They come in asking a bunch of questions. I don't have a lot of knowledge on it, but I know most of it's bullshit. Right?
Yeah. Okay. Good answer.
You don't have to go far before you realise that it's all rubbish research and none of it really matters. In fact, sometimes they'll say a specific chemical, and I'll look something up quickly on Google, and I'll tell them why the study they looked at was rubbish. You can do that pretty quickly with a lot of stuff, right? So that's that kind of stuff, right? But then there's the injections into the knee. So there's the cortisone, PRP, stem cells. So cortisone, we know, at best, will give people 7 days relief, better than giving them a placebo injection. That's what the randomized control trials say. So I don't prescribe it routinely for people with, say, early arthritis. I tell them the chances of making it better is only at best 7 days. So if you have to go to your son's wedding overseas or something like that, you've got a big event, okay, mate, we might get you through that. But otherwise, if you do give them, it does increase their risk of getting infections later when they do get a knee replacement. For example, you shouldn't do a knee replacement within 3 months of having cortisone injection. So we think that it also increases, the more that you have, we also think that it increases your risk later down the line, years later, theoretically. So I just try and avoid them for that reason. Stem cells, there's very poor evidence, really, really poor evidence that any of it works. You can go overseas and get stem cells. I've seen patients come back with horrendous infections, weird and wonderful things. I've seen them with terrible synovitis that's completely denuded their cartilage. God knows what they got put in their knee. I've seen some extreme examples of that, is my anecdote. And then there's
PRP.
PRP, the PRP thing is interesting, right? So there's some evidence that it's out, that it might work. It might relate to the concentration of PRP. It's not something that I prescribe. It's something I tell patients that I think there's really mixed and not very robust evidence out there that it actually works. I think the gain in what the research tells us is, in terms of functions, is actually not that high.
Yeah.
And so I say to patients, look, I don't really think it works. I won't prescribe it. I don't give it myself. But you can go and find a sports physician that will give it. Yeah. But it is super expensive. It's really expensive.
Look, I get asked about PRP, not just for knees, but for a whole bunch of things.
Yeah.
And so I get asked this all the time. And I've looked into the evidence. And the evidence is it's 50-50. Like, it's kind of it's not really swaying one way or the other very convincingly. So, but patients also report that it does work in a lot of instances too. So you've got to take that on board as well. But I think my theory on it is that where there's good blood supply, PRP will have a better chance of working. That's what I found. So
where would you think that might be the case?
Well, I guess, with the knee, the meniscus has got, 2/3 of it's probably got poor blood supply.
Yeah.
And so I would be less inclined to say that it would work on meniscus or cartilage in the knee. Tendinopathies, on the other hand, would probably be a better place to use PRP, and I've seen better reported outcomes with tendinopathies. So that's just the kind of framework that I operate on. So if people ask me, when they get the tennis elbow, the epicondylitis stuff, and all their tendinopathies, I guess, that PRP has actually worked before quite well. But when they ask me about knees and cartilage and meniscus, I tend to say, look, it's probably not going to be the silver bullet that you're looking for. That's just been my experience.
I'd agree. I think that's a pretty reasonable summary of it. Yeah, I'd agree with that.
Yeah. All right. Well, I want to talk to you about ACL reconstructions, and I guess give us a brief overview of what actually happens in an ACL surgery. Very brief. I know it's complicated, but give us your brief little take on.
Yeah. So keyhole surgery, we put the two little cuts at the front of the knee and put the arthroscope inside. Check that everything else inside the knee looks fine, the cartilage surface has no meniscus tears, and specific types of meniscus tears we're looking for that can occur. Some of them can catch you out later down the line. And then we prepare basically the stumps of where the ACL is torn off from. We shave all that back to create a nice flat surface. And then the most important thing is that I believe in an ACL surgery is where the tunnels go. So that's where the position of the ACL actually is inside the knee.
Yeah,
it's the critical factor.
That is the most critical factor.
Yeah.
And I didn't put that as part of my answer to what you asked me before about your surgeries compared to other people's, is that you guys I've never seen an error on that from any of your surgeries, either yourself or Leo.
Yeah, I mean, I wish I could say there's never been an error. I'm sure that there is. We sometimes always, it's a target area and it's a probability. And I think when you do enough of them, you get good at getting them good. Not always perfect, but yeah, batting average is pretty good. So then you've got to find the position of those tunnels, and there's different techniques that we use to sort of localize where we want to target onto exactly. Onto the anatomic position, what we call the anatomic position of the ACL. That's the original position of it. And then we drill tunnels, sockets basically, inside the bone. There's a graft that we use as well. The graft is it's just a collagen scaffold, right? So we could use your hamstrings, your patella tendon, your quadriceps. I could use somebody else's tissue, which we call an allograft or cadaveric allograft.
Yeah, I'll discuss that with you in a minute, but let's just talk about the process at the moment.
Yeah, we then put that inside. We fix it. We fix the graft in place, and again, there's different methods of doing it. Some people use buttons, screws, posts. Leo and I use a screw specifically on both the tibia and the femur, and that's kind of it. You're kind of done once you secured it all in place. You close up the wound, put lots of local anaesthetic in there, and then off to recovery to start the rehab process. Yeah,
right. Okay, so I guess then that leads me on to my next question. Most ACL surgeries are still done using hamstring or patella tendons. Yourself and Leo are one of the too few practitioners, I'm sure there are probably others, that are now using allografts, donor tendons basically, and using those instead of a person's own tissue. Explain to us why you think that's superior, and I guess how that particular method has evolved and why you're using it now. Hello everyone, I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
So yeah, cat allograft. It's a controversial topic, right? And it's something I get asked a lot about. It's something that I do believe in, but it's about the particular type of tendon you use. Allografts has been around for decades, and in general, and if you Google this, you'll see that it has terrible results. It has really high failure rates, which I agree with. The historical perspective of using allograft is bad. There is a history to that though. So in the US, about 30% of ACL surgeries are still done using allografts, cadaveric tendons. Their rates of donation compared to us bodies and stuff, tissue donation, very different. So, and their ability to use it much more easy. So there's some things that we've learnt in the last decades, and my research groups have published on this. Leo's published on this, looking at the age and the sex of the donor. It makes sense, right? If I put a 70-year-old's tissue into a 20-year-old, it's not going to be very good tissue. It's not something that we really thought much about, though. It's not something we had access to previously as well. Where that tendon was processed in Australia mattered in Leo's data bank, right? We had different failure rates from different tissue banks because they were doing different things with the sterilisation process. Washing in bleach, in peroxide, in chlorhexidine for different amounts of time. That's going to denature proteins in a different way. The biggest reason we see failures in allografts, and we see this in a small group of patients that are in Australia because only a few companies do it, but it's irradiation, and that's where you see the really big high failure rates, particularly in the US databases on this. If you microwave it, it's a really cheap, effective method of sterilising tissue because you're going to take someone's tendons, you're going to put in someone else, you've got to make it sterile, right? So you can cook it in a microwave, but it's going to cook it, right? It's going to make that tissue bad at that point, and that's going to lead to really high failure rates. Then probably the last factor is the type of tendon that you take. Classically, if people are going to use, surgeons are going to use an allograft, they're going to order something big because they want more size because they're going to then cut it down to fashion it, right? Makes sense. So what's big? Achilles, patella tendon, quadriceps. When you're a 50-year-old male, you think about people that you know, right? Where do they start getting tendinitis issues first?
Yeah.
Achilles, patella, quadriceps, right? That's what has high rates of tendinopathy. And I think if you take those tendons and you use them, I think you've already got crappy tendons you're starting with. So even though if you bring the donor age down, you use bad tendons, yeah, they're going to have high failure rates. So put all that together, right? We've got the age and sex of the donor matters, which tendons you take out of them, and how you process them. We have now technology. We use a specific company that has this thing called supercritical sterilisation, and we published our what's called our early results, our 2-year results, on the first couple hundred patients, and the failure rates were really, really low. In fact, that's been published in the American Journal of Sports Medicine. It's just come out last month, actually, finally, after waiting for so long for it to be published.
And their failure rates are, I guess, lower than a person's own hamstring? Or comparable?
They're very comparable, is what I would say. So the study that we've done it's not a case match study, it's a cohort study, and it's to follow a group of patients, the first 200 patients that were done out of the clinic using those graphs. So it's not matched to another cohort, but they're still really low failure rates, right? So we're looking at like kind of less than 3% basically have failed at the 2-year mark. And all those patients had some risk factor, like they were either less than 25 or they had a high posterior tibial slope or they're hyperextended, like there was other additive factors. If they didn't fall into those added like high risk categories, then they didn't really, that none of them went on to rupture. At the 2-year mark. We've got MRIs to follow them up. That's a separate study that's coming. And these patients are now coming up to their 5-year results. So that's how long research takes, right? And how much work goes into it. These patients were studied at the 2-year mark. That was years ago. We've finally published on them. We've actually, as soon as we published on them, we're already following them up again at the 5-year mark to see who's failed and who has not. We're calling them and doing all that sort of stuff to work out what's happening, and then we'll publish that as a 5-year paper as well. Take another couple of years to get there.
Right, but you're doing this at the moment, like you're doing this in your practice, right? Like you're recommending this, and it's not like you're waiting. I mean, you're doing the research. This is the thing about research is, if you wait for research to tell you what to do, you're going to be 10 years behind what's going on, and
yes,
that's probably.
I think I would say that what I do is a bit different. Like, there's lots of other ACL surgeons out there that would disagree with using allografts in general. Leo and I are lucky. Leo, Justin, and myself are lucky, I should say. We get first pick of the grafts that come into the country. It means that we get to know the category, what tendons we're getting. We get to know the age and sex of the donor, and we know that tissue quality is good for that reason. It is a limited resource, right? It is human tissue, and it's expensive. It's not cheap for the healthcare system. So it can't be anybody that just uses it to start with, because it is just a limited resource. So not everyone gets to have it. We're very lucky in that sense. So is it for everybody? No, because not every surgeon gets to use it, and not every patient likes the idea of it as well. And some patients, they want something that they might have some more longevity to it, and I can totally understand that, right? And if patients want a specific thing, if that makes them more comfortable, then that's okay. They probably, I can refer them to someone else that probably they can give them that solution. I think the most important thing is the patient is comfortable with those decisions and choices. But patients that come to me generally know what they're going to get.
From our end, it's made the rehabilitation process so much quicker, because we don't have to rehabilitate a hamstring now. We don't have to worry about getting them to, be able to sit and stand up off a toilet seat and not hurt their hamstring. We don't have to worry about them getting in and out of a car and not pull their hamstring. I can get them into extension straight away. So literally, you're doing the surgery on a Wednesday. They'll normally see me on the Thursday, and extension work will start on Thursday, because I don't have to worry that there's a torn hamstring there that I can't extend for the first few weeks, for the first couple of weeks. So it just removes time off that rehabilitation nicely.
So I reckon those factors are important then when you look at the other end of it. You come out 9-12 months out the other end. What's important from a failure point of view? One is that you've got a graft that's strong, like other autograft is. We think it is. It's bigger because it's already been pre-sized. Like if I take out, my hamstrings, I reckon I'd have probably a 7mm hamstrings. My mum would call them Indian coffee stirrers, right? They'd be tiny. But in a patient like myself, I put in a 9 or 10mm graft, so I'm going to be volumetrically bigger. It means that it's going to be stronger in size, hopefully as well. It means that you can do earlier rehab, so your quads, your hammies, they're not wasted away. You got hamstring control and you got your dynamic stabilizer back, and you got somebody who's on an earlier rehab pathway. So I think theoretically, and I don't know the answer for sure, but I think all those things matter to getting a patient who's coming out the other end, who looks a lot better.
And it's less, I guess, less secondary problems higher up the chain. I mean, I've seen the hamstring pulled out. It's not slight. It's like, you can't see it on screen. It's massive. Then you got to roll it over, I think, 4 times to get it to the thickness that you need to get it to. And when you remove that, and then you look at the mechanics up the chain, attachment to the ischial tuberosity, the pelvic girdle becomes has less of a stable fulcrum that it can kind of pivot off. Other things have to pull and take up that slack, and that's where we see a lot of the dysfunctions higher up the chain. So removing all that just makes it that we have to do less work. I want to, I guess,
sorry to interrupt, Sammy, but I will say I still do some hamstring grafts, so I do them in the public hospital, in the public sector. There's a cost associated with allografts and limited resource kind of thing. And I get to see my patients side by side now. And there's other factors that go into it. But the hamstring.
Leo did my ACL back in 2012 with a hamstring.
With a hammy. Yeah.
With a hammy, right? And
how's yours?
Great. It's great. It's fantastic. It's great. It's my left one stronger than my right. So I'm not against the hamstring. It's just anatomically and physiologically, it makes sense that you take a big chunk of your hamstring out. you're going to put another 4 to 6 weeks on the back end of that rehab, and you're going to have some issues up the chain. I was quite fortunate that I had somebody that could treat all that. I want to ask you about, there's been some recent media about healing of ACLs on their own once they rupture. Can you talk to us about that a little bit? It kind of gets some media attention, but is that something that, I mean, it happens, but how prevalent is it, and can patients rely on it?
So I mean, the bracing thing has created a lot of media attention, social media attention. It's gained a lot of popularity recently in the last couple of years. Can an ACL heal? Yeah, absolutely. I've told patients that forever. Leo taught me that when I was a registrar, when I was a baby doctor, right? And the critical thing is a patient comes in to see you 4 days after their injury with an MRI scan, and we go, great, have your pre-ab, and come back and see me in 6 to 8 weeks, and we're going to reassess your need. That was always what we said. Because a percentage of people will go on to heal their ACL. So it's a misconception that you can't heal your ACL. You absolutely can. It can heal. It can heal well. It can heal poorly. It can heal to the wrong structures. It can do all those things. A brace will probably help that to a degree. Like, for example, we know that from when you have an MCL and ACL injury, you come in and they've got a grade 3 MCL, they've got a grade 3 Lockman's. Both are gone clinically. The MRI supports your diagnosis. You put them in that 30-90 brace and you come back in 6 weeks. The MCL heals, and a percentage of people will go on to heal their ACL at that point because they're stiff, they're in a brace, right? And the fibres will just, gum together of the ACL. So it's possible. It's not common, but it does happen. And importantly, is that ACL that heals it can be just as strong as any reconstructed one. It can be just as strong as the original one, in some circumstances. The truth is, we don't really understand it or know it very well. This is the problem. So I like that the Tom Crosser studies really put that out in the media so that we know that it can heal. So it's kind of get through that misconception. The question is whether the brace in that position is doing people a good thing or not, and then what are the longer term outcomes. So I think while some of the results might be quite promising, I think it'd be very careful to jump upon stuff that looks really nice and theoretically really interesting, but potentially not the best thing in the long term, right? So what do I see? And this is my anecdote, right? And like people see my complications. Sometimes I don't see my own. But I see complications of braces. I do, yeah. And we've had big discussions about this at things like the Knee Society in Australia. Arthropfibrosis, quadratrophy. I've had 2 ACLs that have healed in like funny positions where they've lost range of motion, and it's put people back by a long period of time. I've seen a couple who have gone back at 6 and 9 months back to pivoting activities, and they've ruptured at that point. But then they've ruptured with a buck. 2 patients of mine they've ruptured with a buck and handle tear after being in a brace at 90 degrees. So, and then I've had one that's had the complication of a DVT. They wouldn't put on blood thinners. That was probably my biggest concern at the start, right? So the blood thinner issue, and the study makes note of this that says. We realised that there was an error in the protocol because someone developed a DVT and everyone gets put on Clexane now. But I see some physios, I've seen some allied health practitioners who are prescribing a 90-degree brace for an ACL injury, but they're not putting patients on blood thinners. Now, those patients are high risk for getting DVTs. They're high risk for getting PEs. That means that they're high risk for dying. So who's taken responsibility for that?
Yeah.
Like, where's that information in the whole picture? I want to know, like, that's if you're going to treat something, you got to know what the complications are, and you've got to be in the right place to deal with those complications or know who to contact. There's probably some people that's okay to go into brace, but you've probably got to have a medical practitioner on board as well. Someone's got to okay it. Someone's got to say this is appropriate or this is not as well, because the physio's indemnity is not going to cover them for that patient's death, right? When they family sue. Yeah. So I have some reservations.
That's a tough one. The I guess moving away from that really heavy complication, what we tend to see in terms of bracing, especially with knees, with ankles, they're the 2 most common ones that we see, is sometimes the bracing itself can cause more damage than the actual injury that they've come in with. Because if we take an ankle for an example, you'll get like something like a a rupture of the anterior talofibular ligament, and some practitioners will moon boot that. They'll put them in a moon boot.
Yeah.
And if I see that, I get them out of it straight away, because if they're in a moon boot for 4 weeks, okay, the ligament's healed, but now the stiffness through the tibialis anterior, the perineals, and then the retinaculum, all the ligaments, the deltoid ligament, which is so tough, everything tightens up, everything becomes at 90, it just sits at 90 degrees, and it causes so many mechanical problems up the chain. I mean, in a closed mechanical chain, as soon as you lock the ankle at 90 degrees, nothing else is moving. And so it causes a lot of issues that we have to deal with. And the same thing with the knee. If you brace the knee and you allow those ligaments to, especially the knee, especially knee extension, if you don't have full locking of that knee, you will develop some lower back issues later on. Your hip arthritis will accelerate, and and I guess you'll just be in a dorsiflex position throughout your gait pattern, for most of your gait pattern. So knee extension, in my view, is such an important position to be able to achieve, and a 90-degree brace is going to, I guess, not allow that and make our job harder to try to get that to happen. So even if it rehabilitates the ACL and it grows back, it's going to be very hard to get them to lock that knee back out. It's just difficult to do.
So I think that's pretty critical, right? You're talking about robbing Peter to pay Paul. So you've got an ACL healed, but at what cost?
Yeah.
So everything has a potential downside, right? And I reckon early rehab, whatever treatment you do, you decide to have surgery, reconstruction, repair, whatever, right? The early rehab you can do in general, that you can do safely, is probably the most important thing. It's the principle that I apply for almost everything, right? Joint replacement, arthroscopy, ACL, a fracture. I try to get them moving as soon as it's safe to possibly do. So in principle, I don't love the idea of a brace for anything, right? So I don't put my meniscus repairs in braces. I don't put my ACLs in braces after. This is where we're merging here, because again, it goes back to the question you asked earlier. I had a patient come in, I think about 2 months ago, from another surgeon. I won't name the surgeon, and ACL reconstruction, and I was told not to touch it for 6 weeks. Right, so they came to see me, and they were just semi-flexed, and the thing was like a concrete block trying to get it to extend. And I was like, "What happened? Why have you taken so long to get in here?" Oh, that's what the surgeon said, not to come in 6 weeks. I mean, that's treatment from like the 1990s, right? Like that's put him in a cast and like bring him back for 6 weeks.
Well, he wasn't in a cast. He said, "Don't touch it for 6 weeks." You know.
What? I don't get
it. I don't understand it. I don't understand it, and I guess, there's not much we can do. I guess I don't know what the answer to that is. All right. Well, look, you've explained the ACL in good detail. I want to ask you about osteotomies, and I guess for people who don't know, a high tibial osteotomy is where we change the loading from the medial meniscus, which is quite prone to wear and tear, to the lateral meniscus. Is that correct? Or to the lateral compartment, I should say, rather than the meniscus, the lateral compartment of the knee.
Yeah, so there's different ways you can do an osteotomy, and it depends. Are you varus, bow-legged, are you valgus, knock-kneed, are you neutral? It depends where your pattern is, and you can do it on the femoral tibial side. You can do it for other reasons, because you have rotational malalignments, things like that. But yeah, most commonly we do it, say, for a person who might have varus arthritis. They might have lost the meniscus when they're 20, they're now 40, they're still pretty active, and you might want to realign them. So they might have a normal lateral compartment, and when you load up that lateral compartment clinically, you load them up on the examination bed, and they go, yeah, that feels good. I don't have any pain anymore, right? And you get an MRI scan and X-rays that sort of fit with that. So they're a good candidate for doing a realignment procedure. So that involves cutting the bone, and you can do it in different ways, where you cut a wedge out, or you put a wedge in, basically, and that will change the overall alignment to their limb. And it's a salvage procedure, right? It's trying to rely upon what's still good in their knees, trying to keep them away from having a joint replacement. We call it a joint preserving procedure.
Right. And so is the idea to have them just not have a total knee replacement? Or is the idea to get them to the point, say they're 40, you can't do a knee replacement at 40. Do you just say to them, look, let's do this, and we'll reevaluate your knee at 60 and see where you're at?
Yeah, kind of. It certainly, you want to try and avoid doing knee replacements in young people. We know below the age of 50 they have high failure rates, high rates of dissatisfaction, and low, probably poor function. So we want to try and save their knee for as long as possible. We published on this, and again I think it was published earlier this year, looking at Leo's osteotomies from the 20-year results of them, and we found that if you choose the right patient, so that's somebody with a BMI less than 30, a WOMAC score of more than 45, so that's kind of like mild to moderate symptoms, like not really, really severe, and their age is less than 50 or 55, I think, in the study actually. If you have those three factors, there's probably more than a 90% chance that they're going to keep their osteotomy for more than 20 years from the 20-year follow-up. I mean, they haven't converted to having a knee replacement. If you start to introduce some of those factors, like they get overweight, they start to get older, their symptoms start to get more severe, then an osteotomy becomes a slightly less reliable procedure. That's just some of the factors that go into this. It's like a whole composite of things that can affect your outcomes. But I think in the right patient, in a young person who's reasonably active, who wants to kind of stay a little bit active as well, it can be a great operation. And I think Leo taught me how to do osteotomies in a very manual way, and a very like...
I've seen him do it with the protractor, with the X-ray.
Yeah. It's super elegant operation to watch him do, right? It's like one of my most favourite operations to watch after him doing an ACL, right, is an osteotomy, because it's really slick and it's very well done. But it is a game of precision, right? So he can be really precise with his cuts. I started using more technology now. I love everything technology now. So robots, and I use like 3D printed guides. So we do some preoperative planning with some engineers, and they print out a model of the bone, and we work out how much we want to correct the deformity by. It takes what's a really elegant carpentry operation to being really precise, I think now, to millimetre degree accuracy, and something that's now quite very reproducible and very quick to do. So recovery-wise, we talked about this before, right?
Yep.
Tissue handling and stuff. I reckon my osteotomy patients, they get up and they go really quickly.
Yeah. All right. So why would we prefer, I guess, a high tibial osteotomy versus a partial knee replacement?
Yeah. So that's a really good question. That's like an orthopaedic surgeon exam question. Actually, that's a pretty classic one. There's certainly factors of... So, to give you my background, I will do both. I'll do both. I probably do more osteotomies than I do unicompartmental knee replacements. I think the reason I do that is because of maybe what Leo's taught me. It's also my patient demographic, right? So I'm seeing patients that have followed up from Leo, they've had one on the other side, or Leo sent them over to me for consideration of an HDO. Or they've got a post-traumatic arthritis, right? So they've had a young ligament injury, meniscus tear, it's led to this problem. So they're good candidates because they say active patients. So the osteotomy for a more active patient, I think, is a better outcome. In the person who has degenerate joint disease and it's progressed slowly over time, and there's probably some genetic factors involved in it, there's some alignment-related issues, and they're now getting into their 50s and they're living a slightly more sedentary lifestyle. They're not a farmer, they're the librarian or something like that, right? They want a different goal. I think a unicompartmental knee replacement is a wonderful operation for it. Right. So they have, in my book, I think they've got slightly different indications. One's probably going to be more impact, more longevity in their knee. The other's kind of pottering around, not doing quite as much, not putting as much load, do their unicompartmental knee replacement. So just to clarify, a unicompartmental knee replacement, Sammy, you already know this, but it's just when you replace one part of the joint.
Yeah,
right?
Right, yeah. So it's usually the medial compartment that gets...
Usually it is, yeah. Usually.
Yeah.
So the bit that's made that easier for me is certainly the robotic knee replacement part of it. So in the Australian Joint Registry, that collects every patient that's ever had a joint replacement in the last 20 years in Australia. Everyone gets coded, categorised and followed. And you can work out when patients have come back for an operation. So we can work out what the failure rates might be of prosthesis techniques, things like that. We know that when you use a robot, when you do a unicompartmental knee replacement, the survivorship is much better down the track. The early failure rates are much higher, infection and some other issues. So there's this really early spike in them. But then as time goes on, as they get past 10 years, the old school techniques of eyeballing and whatnot to do a uni compared with the robots, much better than the robot. So I'm comfortable to apply it in certain circumstances for that reason.
Yeah, I guess, look, when looking at it from our point of view, especially as an osteopath, the tibial osteotomies present a bit more of a challenge for us because it realigns the mechanics and it changes their loading pattern, especially in the lumbar spine and through the pelvis.
So what do you see commonly? What's the common things that you see?
The common thing, so when you I guess start to take the load onto the lateral compartment, you actually tend to find that the loading through the lumbar spine prefers the surgical side.
Do you reckon that's because they got a shorter leg?
Partly, yeah. They might end up with a shorter leg. So we have to always correct that with if we might correct it with orthotics. But generally, people with osteotomies, like you said, they've got that varus deformity that's caused the degeneration, and we've already usually put orthotics in there to try to help them with that. And so it could be because of some shortness in the leg, but generally it's also because just the shift in the actual line of mechanics, and the lack of bend in that knee, right, creates more of the leg becomes like a stirrup, and the lumbar spine prefers a sturdier surface than not, and so we tend to find that there's just more loading on that side.
That's interesting.
Also, what you got to understand too is you'll get. So what we find is that we get more wear and tear through the loaded side anyway. So, okay, so you're a young soccer player growing up. You know, you're a right-footed player. You kick with your right foot. Well, to kick with the right foot, you've got to balance on your left leg. And so throughout the entire life, you generally tend to have a loading pattern that favours the stronger leg, which for you will be the left leg, because that's the leg that you load on, because you kick with your right. Now, over time, that will create more wear and tear through the left leg, and that's generally where you'll find the problems and the injuries that'll happen. And so you already prefer that side anyway. Then you go and do the surgery, and you just double up on that. Okay, so it's something. Sorry, it's a pattern that we see in the clinic. Sometimes you get little divergence of patterns, but that's part of it too. It's not just the shortness is a part of it. The neurological kind of build up over the many years is a part of it, and then the surgery just adds on top of that.
I guess it's important, right? Because you don't want to be. We're not doing these on patients who are functioning well, right? So I wouldn't offer an osteotomy to somebody who's like living their life no pain or niggling pain, they're getting around fine.
No.
This is an operation for somebody who's struggling with something. Right?
Yeah, like a young person who's waking up at night with pain in their knee and they're not getting sleep and
So it's not a perfect cure, is it?
No.
Like there's always like you're robbing Peter to pay Paul again. So there's going to be a downside somewhere. And when you start screwing around with alignment on people, you start changing things that they have progressed into naturally, they're born into. It's gonna create some problem somewhere else.
All right. Well, I guess the last one that I want to talk to you about is the total knee replacement. And I've been quite privileged because I'm telling you that I think the surgeries are fantastic, but I think 99% of the surgeries that I've seen of total knee replacement have been from either you or Leo, and so I'm getting good surgeries, mate. So that's why I tell people that I think the surgeries are fantastic, and the outcomes for me pre and post op are like, patients are having a hard time walking, they can't function, they're waking up at night with pain, and not only that, the knees are actually affecting other parts of their life. They become more sedentary, their asthma develops, their other arthritic problems develop, and then basically the longer we wait to replace this knee, the worse other things are getting, and that's not really a good thing. And that's why I always say that they're great surgeries, because they not only just fix the knee, they fix other parts of their life too.
Yeah, and that's kind of the hope, right? That we get people back to function, right? Right. That's the coming back to what I talked about. Why do I like orthopedics is to get people back to their function. And hip replacements have certainly been like that for people. It's called the operation of the century, right? And I think knees are starting to catch up to that point. We're not there yet, but we're getting closer to it. It's a different kind of joint, and it's a different pattern of arthritis. Knees are a far more complex joint, so there's a lot more that goes into why people might have bad results or unhappy patients. I think, yeah.
So what don't you like about total knee replacements?
I love it. What do you mean? What I don't love about them?
No, like I mean, I said earlier that I think the surgeons are great. And you said to me, oh, look, I'll disagree with you a bit later on that. So let's flesh out your argument now so that we understand where you're coming from.
So I think a knee replacement is good in the right kind of patient, right? So you have to choose the right patient. They have to have the right kind of symptoms. They have to be functionally disabled enough. They have to have X-rays that show that they've got bad enough arthritis to justify doing it. And then there's probably some patient factors, particularly in terms of expectation going into it. And my conversation with patients when they have arthritis, it's probably 15 to 30 minute conversation just about management of arthritis. It's complicated, and there's a lot that goes into it to talk to them about it. So I kind of I'm trying to set the expectations, set the bar appropriately for them, right? So the best example that I have to summarize that is when a person comes in, and we do a whole bunch of different scoring systems when they do my patient registration form, and they go into our database. One of them is like an Oxford score, Oxford knee, Oxford hip score. It's a pretty rudimentary tool. It's not a perfect tool, but it's pretty easy to understand. And so, like, I think Oxford's out of 48, something like that. Now I've got to think about it for a second. But essentially, yeah. So if we look at most of my patients, the average that they will come in with when they get a knee replacement is about 18 for me. Some will be single digits and some slightly higher. After doing a knee replacement on somebody, I can improve their Oxford score by about 22 points. So I take them to that 18, 20 mark to 40, 42. But they're not 48. They're not perfect. So if someone comes in and their Oxford score is 40, and I use this as an example, right, where they've scored all these things, and they go, oh, I'm horrible, I'm not doing that well. I go, here's your Oxford score, right? You're deficit on 8 points. If I can improve people only by an average of 20 points, where do I take you? You haven't got that far to go. So and again, you see second opinions, you see unhappy patients, and most of them, when you look back at them, there's something in the history. Not always, but there's something in the history. There was a person who didn't have symptoms for that long. They weren't treated with enough conservative therapy. The X-rays weren't that bad enough. Their Oxford score, if you look at it globally, their Oxford score wasn't that low, and they got a joint replacement. They got major surgery. They went through a hell of a lot of rehab. They went through 1 year of shit, only to come out the other side, and they're not that much better. So the knee replacement that you put in somebody, like if I put in your knee, Sammy, you'd hate me. You'd go, this is horrible. It's not like a natural joint, right? Yeah. It's not going to feel like that, and it's not going to be like that after all the scar tissue and rehab and God's wasting you're going to go through. So we don't take normal joints and replace them. So we have to kind of be bad enough to justify doing them. So there is a percentage of patients that are going to have a bad outcome because we don't always get that perfect mixture, right? Sometimes we choose badly, sometimes the patient chooses badly, sometimes we do a bad surgery. And in general, if we look at the worldwide literature, they say 80%, I still say 80% of patients when they come in. We look at our database out of North Sydney Orthopaedics, NSOR, North Sydney Orthopaedic Research Group, and we've got about a 92% satisfaction rate. Again, I think that comes down to a lot of patient choice as well. Like who are you putting through this operation?
All right, let me give you a scenario and get your opinion on it. I had a patient who was a long time football player, soccer player. His knees are worn out. I mean, he's had multiple arthroscopies. The crepitus through his knees is just awful. And he's a builder. And I can't straighten out his knees. His knees are just constantly semi-flexed. He's not in huge amounts of pain all the time, but it's affecting other parts of his. It's starting to affect other parts of his life. He can't be as active as he'd like to be. He can't lift weights. He can't squat down past, probably 50 degrees. He can get down to a chair and stand back up, but it's painful. And although he's getting to 60 years old, he kind of asked me the question, what's happening with my knees? What can we do about them? And I know that his arthritis is going to get worse. Like I've seen it, and I know where this is heading. I know he's heading towards a knee replacement because he's not a small guy, but he's a builder. Like he's a thick guy. He's not even. What's he going to go and lose? 10 kilos, 20 kilos. I don't think that's going to happen. I don't think he's going to, have all the time in the world to do the strength work that he probably should be doing. And even if he does it, I don't know if that's going to give him now, at the point of degeneration, that much benefit. And so his advice from the GP was, they said to him, look, Mick, mate, just wait till you can't bear the pain anymore, and then go and see a surgeon and see what they tell you. My advice was a little bit different. My advice was, why wait until you can't bear the pain anymore? This is obviously affecting other parts of your life. You can't fully straighten those knees. You come to see me every 3 or 4 weeks with a back injury. You can't exercise. You can't do the things. His markers are deteriorating. He's got cholesterol and all this kind of stuff. And I'm like, why wait till all this stuff degenerates to the point where we can't help you with the other stuff? And so my advice to him was, go and get it done within the next 12 months. Don't wait 3 or 4 years until you can't go to bed anymore and wake up without pain. So that was my advice, but what would your take be on that?
I think it's pretty reasonable to say to that kind of patient, you should go see a surgeon for an opinion, importantly. So I think when patients come to see me, they're not coming to see me for surgery. Maybe some of them are, and maybe some people are being sent for that reason, but when I see a patient, it's always to give them an opinion. Most of my consults most patients I meet do not end in a surgery. If I did, I'd be retiring when I'm 40 years old, right? That's not going to happen. Like, most people that I see, they're not having surgery. I'm talking most people out of having operations all the time. But I think, importantly, someone like that, it's time to engage with what that process kind of starts to look like. So if I saw him, and I think it sounds like it's the kind of guy that now's the right time to come and get an opinion from a surgeon, because I'm going to give him that conversation about just even the 1 or 2 kilograms, right? Reducing the lever arm on his knee when he goes up and down stairs, goes up and down the ladders, that's going to make a world of good. The evidence out there is pretty good for weight loss. Like, it's very good when it comes to non-operative management of arthritis. The physiotherapy programs, the use of non-steroidal anti-inflammatories, that's a pretty, for most people, a pretty innocuous drug, but can help a lot. These things help, right? And it can probably push him along to the point where he starts to look at, he's a builder, he's going to look at trying to wind down his career over the next 3 to 5 years maybe, and he can start to think about the horizon. And he can start, more importantly, he's educated. He can start to target and focus where he's going to go to. It's harder when he just turns up and goes, hey, I want to have a knee replacement. Because also, he hasn't had that discussion. He hasn't had time to think about it. He hasn't had time to understand what his pathology is, from a surgeon's perspective maybe. He hasn't tried some of those other medications. And when I give him some meds, he'll be like, what the hell is this? Why should I try this? I just want my knee replaced. And I think it's like a journey for them as well, right? You can't just say, here's one therapy, move to the next. They've got to kind of go through the motions a little bit to understand where they're at and how bad their symptoms are. And often that conversation that I have with a patient, it's trying to put their symptoms into perspective. And 1 or 2 things are going to happen, right? The builder who goes, yeah, I get it, I know my knee will replace, I'll come back and see you later. And I go, yeah, that's fine. Then there's a person who's like, oh, I can see it in their face, they don't really get it, or they don't really understand what I'm saying. That's a person that I say, let's do a telehealth, let's have a phone call in a week's time, because I've given you a med or something. I use that as an excuse to let's check back in again to see where you're at, to make sure that you're educated, you understand where we're going. And then there's a person who needs to have a recalibration of their expectations. I think the discussion about the Oxford score and where they're currently at. any point of view. So I would say now's the perfect time for Mick to check in with the surgeon. It might not be the right time for him to have surgery. There's also other factors, right? He's got to think about lifestyle. What does it look like from time off? The 2 to 3 months off heavy labouring work, the 6 months of rehab, the 12 months of really where he's going to get to in life, the financial implications. Are we going to
is your recommendation in terms of time frame quite reliable? Not just your recommendation, but a surgeon that would have good experience and is aware of the literature. If you look at a patient like that, could you confidently say to him, look, you may not need the surgery right now, but it's good that we start the process of getting you educated. You're probably going to need it in the next 24 months, something like that. Is that something you
No.
don't do, or is that something that you...
No, I rarely do that. So the first thing I say to anybody, if someone goes, "Oh, there's someone said I need it," I said, "Bullshit. No one needs no one needs anything ever." Right? Importantly, these are choices, and I always lay the foundation for that. ACL, meniscus, arthritis. No one needs any surgery. These are choices, lifestyle choices that you make, and we're going to help guide you through that process. I can't reliably predict how long someone's going to last, right, with a current X-ray or their symptoms. For some people, their X-rays look terrible, and they're like getting around just fine. For some people, they don't have that bad, and they're complaining about the worst pain they've ever had in their life. So, and how quickly that degenerates is impossible to know. It's impossible. We don't know that. So when people say that, they go, you're going to have knee replacements by the time you're 50. I go, bullshit. How do you know that? These are just they're guesses. They're really guesses. And more importantly is, I think it places an unfair burden on the patient, because it goes, the surgeon that I met when I was 35 said that I'd need them when I'm 50. So here I am when I'm 50. It's already set them up for failure, right? You say your symptoms, you manage them. They're part of you. You have to live your life with them, and you manage them as best you can. And when you need help at the next stage, that's when you come back.
Yeah, right. All right. Okay, so look, moving on from these, I want to discuss the trauma work that you're doing out at Liverpool Hospital. I want to talk a little bit about trauma and some of the things that we should know, I guess, from a surgeon's perspective. So, if you perform, I know it's hard because different parts of the body might require different approaches, but as a general perspective, when you perform surgery post-trauma, what is what's one thing that you would like us to know when we start to, get those tissues healed, I guess? Like, what is something that you wish a lot of allied therapists, physios, osteopaths, you wish they know in terms of how to start the recovery process and then how to deal with the tissues?
So I would actually say that I think the most important thing is the patient education stuff. So I think everyone, and every allied health person knows this, they're going to get scar tissue, they're going to get stiff, they're going to get swelling and pain, right? But sometimes we don't communicate that to patients particularly well. So even though we start down a treatment pathway with them, we kind of sometimes forget that bit. So we need to re-establish that. So what I say to a patient, if I take them out of a cast, for example, they've just had a distal radius fracture and it's had a plate and screws in there. Before I take it off, as I'm cutting off the cast in the rooms to check the wound, I say, this is going to be swollen, it's going to be sore, there's going to be a bit of blood, right? I'm preempting all those things. I'm trying to reassure them that I know what's going to happen. We know and predict what's going to happen, right? So the same thing goes for the therapy, I think. Like, you tell them, we're going to do something that's going to be uncomfortable. And most of the time that pain's going to be okay. Like, it's okay to have some pain when we do these exercises. It's okay for your pain to go to a certain level, and it can stay at that level for a little while, but it should come back down. And if it stays really bad, like if it becomes a 9 or 10, then that's too much. We'll ease back. And if it's like still a 9 or 10 tomorrow, then we should probably look at that again. But if it's just going up a little bit, that's okay. It's part of that healing process. Yeah.
Do you find that therapists that are doing the rehabilitation on I guess an overall generalized perspective, do you find that they're pushing hard enough? Do you think that they could push more than what they think they can post-surgery? Like, once you've done your surgery and you've actually repaired what's going on there, do you think people are very kind of,
hesitant
to kind of push with the rehabilitation, or do you think that that's something that's been done okay?
So I think that's a complicated question, right? So there's the therapists that I know, and like yourself, and that I know what your general ethos is. I know what patients think of you, and I know how you approach things. And we know that we have a communication channel, right? So if there's a problem, you're going to text me about it. You're going to call me straight away, and that's a really easy relationship to have, because it says it's like an open communication thing. So there's a trust involved in that on both ends, and it's good for the patient as well. The patients love that too. Then there's a therapist that I don't know, and that can be really hard because I don't know the answer about how much. Yeah, and so sometimes the patient comes back at 6 weeks. I go, "You've done nothing like this. What's going on?" And in that circumstance, I don't. Like, my first instance isn't to blame the other person, right? I'm trying to look for reasons why it's.
Yeah, but how do you deal with it? Well, you got to get the patient right. How do you deal with it?
I get on the phone at that point. That's what I do. So I'll call the rooms myself. I'll leave a message, and I'll talk to them about it. Okay, hey, what's happening? Like, have you noticed something that's going on? And often, Sammy, it's such a good question, right? Because often the response is, I wasn't sure how hard to push it because I haven't seen it before, or I wasn't sure, or the patient, I wasn't sure what you liked, that kind of thing, right? It's more about communication than anything. So I think getting on the phone, talking to somebody about it, and that's a two-way street, right? So you got to have the practitioner who's willing to do it, but also the surgeons that are willing to do it. I know surgeons can be dicks about it, right? Like, I've heard that a lot, and I know that's a really awful thing, right? Because you've done a surgery on somebody, and it's not even half the battle, right? It's not even.
Yeah, look, the crucial part for me is those first 6 weeks. I'm not sure why, but the first 6 weeks post-operative, for some reason, those tissues are still very supple, and they could be kind of pushed along, but yet it's a bit antithetical because you'd think that the first 6 weeks you need to kind of back off and just let things heal. But in those first 6 weeks, you've got a real good window of opportunity of actually trying to make the most amount of change. I know with ACL stuff that we get the most amount of change in the first 6 weeks, and then we probably get the last 10% in the next 4 months. Okay, so
I think the same thing goes to trauma scenarios, right? Yeah, it's giving you.
But that doesn't. I can imagine a practitioner kind of going and being a bit hesitant, going, "Really? Well, maybe we should just leave it for 6 weeks and then, But that was, like you said, that's the old way of thinking. That's very 80s and 90s. Yeah. Okay. So I guess the message out there for people listening and watching is to get on the phone if you're not sure, and if you are, you're certain that the surgery has been done well. There's physiology behind what you need to do, and just push that to the stress that's required to make a change in the tissues, right? Each tissue requires a certain amount of stress. You just need to know what that is and go there. All right, well, I guess moving on from trauma then, your experience in terms of rehabilitation, I'm sure that most of your rehabilitation providers will be physiotherapists. A lot of them now are becoming just exercise only versus manual therapy or a combination of both. Do you have any take on that? Have you seen, in terms of when you see patients come back to you, do you get any feedback on manual therapy, or is it all just exercise based? Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
So I think there's a combination of both, and there's certainly, what do I see? It's really only what patients tell me about, and they report their experiences, and you'll hear the ones that are unhappy, of course, more often, and sometimes it's the common thing is all they do is get me to do exercise, or it's the opposite side, or all they do is just some massage. In fact, sometimes the things that sometimes, often it's the patients who complain that it's just exercise and no manual stuff, and then sometimes I'll listen to the patient and they go, oh yeah, they like massage me and that's about it. And I'm like, where's the exercise? And they're like, oh, we haven't done any. So there's these two extreme ends that I pick up on or the patient picks up on. And you definitely need a combination of both, right? There's definitely both elements. Like, you're not going to get better just by doing manual therapy stuff, because there's no education, there's no forward planning stuff, right? Rebuilding involved with that.
Yeah, you need to apply
stress.
stress.
Just do the exercises because there's a whole bunch of things that you need to help that patient get over.
Initially, you the patient can't move that. You need to move it for them. Yeah, no, definitely. That's been the experience, I guess, on our end, as we combine the two. And initially, there's a bigger slant towards manual therapy because the patient can't get themselves into extension, I guess, from a knees perspective, in the first 4 to 6 weeks, especially when they used to do the hamstring graft. So we'd have to really kind of push them along. Now it kind of, they can do it a lot quicker and a lot easier on their own, but we still kind of give them a bit of a push along. And then as they improve, we back off on the manual therapy, and the work's done in the gym. And that's all based on physiology. It's not like what Sammy likes or what this person likes. It's just physiology. Like, it's tissue healing and stress. And I can't, no matter what I do, I can't replace what, a 60 kilo deadlift or a squat or a knee, a leg extension can do, or a leg press can do. A 100 kilo leg press is going to do a lot more in terms of stress on the tissue than what I can do with my fingers. And especially the range of motion too. We've been having a bit of a debate within, I guess, allied health, in terms of evidence-based practice and looking at new paradigms of treatment. Like, when you're trying to investigate new theories and new paradigms of treatment that don't have a lot of evidence behind them, what is it exactly that you do? And so I want to ask you the same question, especially with your experience with the donor grafts, with the allografts. That's something that, in its genesis would have been like, hey, why don't we try this? And there would have been no evidence for it at the time. And I guess it's probably a better question to ask for Leo, but we don't have Leo here and you're here, so I'm going to ask you. When there's something new that you're investigating, Keran, a new approach to something, and there's no evidence for it, what's your thought process like? And do you just not do it, or do you find a way to get the best outcome for your patient?
Yeah, so I wouldn't say that stuff that we do has never had any basis. It's got some historical perspective to it, right? If you take the allografting, for example, right? It's been around for 30 years or longer, and there's different forms and fashions of it. And then Leo and Justin have gone into doing, living donors. So they take parents' hamstrings, they put in their kids, and that's pretty avant-garde. That's like kind of pushing the envelope of where, but it makes sense. You've got allografts, you've built upon that, you've got living donors as parents. How else can we build upon it? So where we're currently at with the allografts is we've got a historical perspective. We've got thousands of Leo's patients that had allografts done through the clinic, and we know what those data points were. We know what the donors were like, and we know where the failure points were. So we take that information and then we apply it to the next set of allografts that we're going to get, right? We build upon it.
But you don't know where that's going, right? Like, ultimately, there's still going to be a bit of a leap of faith going on there.
You got to keep studying. Like, and I'm always happy to put my hand up and say that I'm wrong about something, and I might be wrong, right? But I want to make sure that I'm going in the right direction. You can't sit there as a practitioner and do something that's different and avant-garde and a little bit edgy, and then not follow it up and not have the data to back yourself up to begin with, but also to follow through a bit later. So that would be wrong. That would be wrong to the patients that you're treating and the future ones as well. So I think that's really important, that it's got to have the follow-up that's necessary. That takes a workforce, that takes finances, that takes a lot of time, right? That's a big investment on all aspects. So if you're going to go down the path of looking at new stuff like that, investigating new evidence and coming up with research ideas, you've got to be able to understand what you're doing and where you're going with it.
And you got to have the resource, from what I understand. You got to have the resources to follow through with it.
That's the cost. It costs money, right, to do all that stuff. Yeah. So then there's also the patient at the end of it, right? Because we're not just like they're not lab rats. So you have to tell the patients about what's going on. So that's the open consent procedures. That's understanding where they come from. It's them also understanding the perspective of where I'm at. You know, why am I recommending something that's different to the next guy?
Let me then ask you and kind of pivot away from that question into a similar question. When it comes to testing, you know, a lot of the physical orthopedic testing that you're doing with knees, especially, you know, a lot of the evidence coming out now is a lot of these tests don't have very good reliability or I guess validity to what they're actually trying to measure. And so when you approach a test, that I guess do you I guess change the test a little bit to suit the patient? You know, if you find that a certain test is kind of not working out for you, do you kind of make it more functional, I guess, to suit the patient and what's going on there, or how do you go about testing the knee in terms of, you know, like let's look at Lockman's tests and pivot shift and McMurray's and these tests. What's the evidence like for them, and are people still using them in clinic? And if they are they doing them in the way that they're meant to be done, or are they changing them to suit the patient?
So yeah, the answer is probably both. Like you can do the original test, or you can modify it, and then you can argue about how the original test was done in a million different ways. And if you look at some original descriptions, you'll find some pretty surprising responses, right? Like the apprehension test for looking for patellar instability, the description of it is like bizarre. It's like the patient reaches forward to prevent the, you know, clinician from moving their knee, something to that effect, right? It's how it's described. So, or a positive result. So like, you always have to be careful of like what the original descriptions of stuff were. So yeah, we do tests and we do clinical tests because they suit the history that we're getting, right? So we have a patient that's telling us a story. We want to now fit that, try and see which parts of that story we think fit with like instability, for example. Do they have clinical instability because they say that they have functional instability? That means, do they have a positive Lockman's or pivot shift? Part of that is then, yeah, as you say, modifying some of those tests. I don't think I modify a lot of tests myself. I have a pretty standard set of tests that I will do for certain conditions, but I might change the way that I approach it for that particular patient. Like I might show them their other knee that they're not going to hurt. I might rest their leg in a certain position that's different. Like when I do a Lockman's, for example, because they need to be, because they're a bit more guarded, for example. And some things you just can't get out of people. Like you might not get a pivot shift because they're just guarding too much, because they're just too acute. It's not possible. But all that's just data and evidence building, right? So you might have 3 or 4 tests that test for something like joint line tenderness, loading the joint, and a McMurray's test that all suggests this is a meniscus tear. And you go, yeah, I've got 2 of these 3 things, but like, what does the MRI scan? Like, I think it is a tear, but does the MRI scan say that it's a tear now? Because that's what I think it is. So then you're doing confirming along the way and modifying to approach that patient, yes.
And in terms of validity and reliability, all the testing that you use are, I mean, what's the consensus now on a lot of the knee tests?
I mean, different tests have different specificities and sensitivities, right? So the McMurray's test is not particularly sensitive. It's not a particularly specific test either, right? You have someone with arthritis with grade 4 chondral wear, they're going to have a positive McMurray's, for example, right? So it's not necessarily specific. It's kind of reasonably sensitive, but then there's other modifications, right, that you can do. There's like all these other described tests for like loading up the compartment in rotation, or the patient doing it themselves standing, that say that they have better sensitivity. At the end of the day, I think the most important thing is you want to choose a test that you think is reasonably reliable, right? So like, and I don't know what the numbers quoted like in the research on McMurray's test, for example, but let's just say it's 60%, right? But if you can do it reliably and keep repeating it, and you write 60% of the time, that's okay for a clinical test. That's probably good enough. Yeah.
Okay. All right. Well, I guess then, moving away from some of the testing and the evidence that we've been discussing, I've often asked other practitioners in terms of what sets them apart, or what sets, I guess, an average practitioner from a good or a great practitioner. So I want to ask you the same question. Tell us about surgeons. and this is going to be probably purely your opinion, and that's exactly why you're here. What do you think the differences are between an average versus a good versus a great surgeon? Like, what are the things that we need to know as therapists? Like, when patients come to see us and say, "Hey, do you know someone who's a good, shoulder guy or a knee guy or a hip guy?" How do we go about assessing surgeons in terms of good or average versus good versus great?
Sammy, you might disagree with me on this one based on what you said about quality of operations coming out of our group, but I reckon it's got nothing to do with their technical ability. Like, I reckon surgeons being good surgeons has nothing to do with what they do in the operation itself. Like, you can have somebody who's okay at that or pretty average, but that's not the question is, what's the goal, right, for the patient? The patient needs a good experience and they need a good outcome. Now, a good outcome can be a measured success because you've got a test or you've got a scan or you've got a picture that shows that they've had a good outcome, but that has nothing to do with what the patient thinks about that outcome. So it's all about if the patient has had a good experience, and they might have a bad outcome because it's just going to happen, but if they've had a good experience along the way and they're happy with that because they're satisfied with the person that's helped them, then I would argue that that's a good surgeon, because they've delivered on what that patient is trying to achieve. And it might not have gone perfectly every time. Of course, you can't have somebody who's just putting out not great results all the time and just patients are happy with them because they're a nice guy. That doesn't work, obviously. But in general, it's the surgeon who chooses patients well, who communicates well, who does an okay operation, sure, or instigates the right therapy. But the patient has to like them at the end of the day because they feel like they're involved in that process and they relate to somebody in that process. On the practitioner side, I would say that the same things apply, right? Someone who's ready to pick up a phone and talk to you, who's going to communicate, who your patient's going to come back and like, and that you think the patients are getting good results out of, right? Because you think they can rehab quicker or whatever you think it is, right? But yeah, I'd say the most important thing is the communication.
So you've outlined what a good surgeon might be like. Tell us about a great surgeon. I mean, you said the technical ability doesn't matter that much, and you've described to me what a good surgeon will have: good communication skills. They'll have the patient involved in the process. They'll make sure that I guess what we call the patient experience from start to finish is something that they've at least not detested and at best enjoyed, I guess. But like, who's going to enjoy surgery, right? But at least not have it be a very bad process. Once you take that and you layer it with great technical ability, would that then make somebody kind of take them to the next level in terms of surgery?
I'm really hesitant to say yes. Like, I just don't think, like, I find it hard to imagine that it's just the technical skills of somebody. Like, you can watch people do operations, and some surgeons, as a surgeon, I can tell, when
so
someone's...
if you kept missing that tibial tunnel, mate, you were just, the people were really involved in the process that you put them through, like there has to be some form of, I guess, technical ability there. And I guess the feedback from me earlier to you, you could almost see me as an objective measure, because I'm outside of the patient experience in terms of your patient. Like, they're my patient too. We share a patient. But when I put my hands on somebody and I assess the surgery, I'm assessing the outcomes of the surgery. I'm not assessing how nice Keran is, or what kind of experience. I actually don't know really. I mean, I know your processes now quite well, but I don't know many other surgeons' processes in detail. And I guess I can put my hands on somebody, I can assess them, I can run them through some tests, and I can kind of get an understanding objectively of if the surgery's been done well. And that takes a lot of the personality out of the surgeon. Like, we don't really look at the personality or the willingness of the surgeon to bring the patient into the experience.
So I guess the hard way to evaluate people on that level, though, is it's often low numbers, right? Like, you might share a handful of patients with the surgeon, not hundreds, for example. So then it becomes a bit like, we're talking about evidence, it becomes a bit of an anecdote. And
it's phenomenology. I mean, it's just there's a certain amount of phenomenology to it. Yeah, definitely, that's going to be the case.
Have I avoided?
No, you have. I think once You should leave surgery and go into politics, mate. You've done a good job there. But anyway,
you see me squirming in my chair, trying not to answer the question.
All right. So I guess then you've answered that question, because my next question was, what do you look for when you decide to refer on to, I guess, post-surgery to therapists? But can you maybe, extrapolate on that a little bit? You've told us about the communication and making sure the person has good rapport with the patient. I know that there's, like, for example, with Leo and with this, there's like a list of people that you prefer. How does somebody get on that list? Like, what do they have to do?
So often people that I've added to that list, people just call me up. They call me up and they want to come visit for surgery. I love having people in surgery. You can tell that I love talking about all these kind of things, and I love talking about it even more when I'm doing it.
You had one of my students come and visit you a few weeks back.
Yeah, absolutely. I did. I did. And they had a great time, right? That's like a really exciting environment in which they can come and see things. So often it's the person that picks up the phone. So they come and visit and they introduce themselves. I love that. And if there's a good rapport, right, and maybe they're starting out in practice and you want to help them out, sure, you send them a patient. And sometimes it's a bit of a, for both them and for you, it's a bit of a test, right? I know that when patients get sent to me from a person I haven't met before, it's you know that in some way, conscious or not, everyone's getting evaluated, right? On what you do.
There's nothing wrong with that.
There isn't, because how else are you meant to know, right? You've got to try it out. Absolutely. And again, that comes back to all those things again. Like, did you get along with them? Did you get their phone number, right? So sometimes people are left. I've had people come and visit and they just said, okay, thanks, and they've left and said bye. I'm like, okay. Well, it's like, that was a good teaching experience. But like, you leave your details, right? You can message and ask questions about stuff. Sometimes I don't know about, so the things that, so what do I do, right? So sometimes I'll be sitting there in front of the patient and we might have a bit of a deviation in plan, but Sammy, you're not going to get my letter straight away, right? So I'm going to send you a text being like, things in front of me, and John's in front of me, and can we try X, Y, and Z because you see them tomorrow, right? Little things like that are just going to get the patient back on track in the right kind of way. And again, that should go both ways.
Definitely. Yeah, no, and that's, I think people think that, like there's some kind of pedestal that people stand on. And I'm like, like just go down there and introduce yourself and, make a good impression, put your best foot forward, obviously, and ask questions and, and work hard and be humble and be nice. And at the end of the day, you're not going to get what you don't ask for.
No. So one of the things about surgeons, though, is that they're not, they can be different to me, right? For good or for bad, they can be different. And one of the things you'll see a lot of is sometimes surgeons are very standoffish. And sometimes that standoffish is because they are putting themselves on a pedestal. Sometimes it's because they have no social, skills as well, right? We're just a bunch of nerds at the end of the day. And we've just fallen into a career path that's got a title at the end of it. Doesn't make us better than anyone else, and sometimes we just don't know how to communicate with people. So don't always take that as being the person's being rude or they know we're not interested. Sometimes you just need to help engage them a little bit on their level. Yeah,
look, even if they're good surgeons too, if they know that there's that kind of, I guess, dynamic, they'll generally surround themselves with staff that might be a little bit better at that. And so it's always good to introduce yourself to the staff, to the assistant, the surgeon's assistant, the nurse, have a chat to them. And if you find that the surgeon himself or herself might be a little bit, I guess, socially standoffish, there's no reason why that you can't have a relationship with their 2IC.
Yeah, so there's a lot of people inside. So if you have people that turn up to an operating theatre or go visit a clinic or something, introduce yourself to everybody. It's a polite thing to do. It's in a weird environment though because you're the outsider. But just go and say hi to people.
Yeah, take wine.
Take wine, sure. Yeah.
All right. Look, we've discussed your partnership, I guess, now with Leo Pinczewski.
Yeah.
I'm going to ask you, tell us what that experience has been like. I mean, you know, what do you think is the real... I mean, you answered it in some of the questions that you don't think that technically speaking, there's a massive, I guess, emphasis on the technical aspect of what makes a good versus a great surgeon. But what do you think is the subtle, maybe, or not so subtle difference between what he does and what he's taught you versus what you may have learned had you gone somewhere else? Like, what do you think what do you think has really helped you along in that way?
Yeah, so they definitely, I mean, when I look at Leo, I go, there's the technical aspects, right? So I watch him and I watch him do certain operations and I go, the guy's he's an incredibly gifted surgeon. Like, yeah, to come back to your question you wanted to ask me before, because you can do things in the right way and you can do them really quickly and you can do them on point more often than not. And Leo certainly has that in the operations that he does, for sure. You also see elements where you have to think outside the box a little bit. So when you can have, like, most operations are pretty standard, right? If I do 5 ACLs on my list, I'm like in my happy space. Nothing's really going wrong, usually, very rarely. And there's nothing much coming at me. In the trauma scenario, it's a bit different. So when things go wrong, it's about how well does a surgeon react to those environments. Emotionally, physically, what are they doing differently? And how quickly can you think on your feet to do a bit of MacGyver stuff, to problem solve very quickly. I think those are the things that make a technically gifted surgeon a very excellent surgeon at that point. Right? Whether that translates to outcomes is a different story, right? But yeah, that makes good surgeons great surgeons at that point. 3-dimensional reasoning, like knowing where your hands are in space, where they're going to, keep going back to the same point over and over. And one of the interesting things to do with, like, and this was the case with Leo, right? I saw this with Leo, and this is one of the things that I really loved, probably maybe 3 or 4 months into it, when I kind of, into my fellowship, I started to get to ask him more questions, because I was doing optimal surgeries with him at that point. And I'd ask him a question, and he wouldn't have an answer for me straight away, because he'd never had to think about it before. Because often we do things as surgeons and we don't know, like, it's like that competency scale, you know, like you're suddenly consciously competent, unconsciously competent. You're doing things just robotically.
Yeah.
So I had to do it the other day in a lab that I was doing. I run some cadaver workshops, doing some for knee replacements, for example, training other surgeons on how to use them. And surgeons were asking me, why do you do it that way? And I'd have to think, like, really think about it. Like, why do I do it that way? I did the first weekend I ever did at one of those labs. I went back and I did 3 knee replacements on the Tuesday after that, and they were the best 3 knee replacements I'd done in a long, long time. They were, like, slick. Because suddenly those things that I'd have to think and discuss, I had to come up with an answer. And I saw Leo go through that for like 6-9 months with me. I'd ask him a question, why do you do it? And I don't think a lot of people have challenged him on it as well, or made him think about it necessarily. I think probably he also thought, she'd have to give this guy an answer because he's going to take over from me, so I better come up with an answer.
I've said to my students the same thing. It's like, you know, it's like asking Jimi Hendrix, how do you play the guitar? You know, like, the guy just plays the guitar. Like, you know, it just gets to a point where it's an unconscious kind of thing that just happens, and they get so good at it. You know, it's like they're brushing their teeth. It's not, and that's the guy you want doing the surgery, is the guy that's done so many of them that they know exactly, the routine of it is so precise that there's very little room for error.
It's funny you said that. I had a patient, I did ACL this morning, young, lovely bloke. I saw him after surgery, and he goes, oh, it's fascinating. You know, he gets excited that he's going to get to watch the video. I always video the arthroscopy so patients can watch it later, right? And he says to me, he goes, I want to ask you, what do you do? Like, you must G yourself up in the morning, right? Do you play some special music, and do you do like a war dance? You must brush your teeth a certain way before you come into surgery. And I didn't have the heart to tell this kid. I'm like, yeah. But I'm like, no, I went and like poured fuel in my car this morning. I picked up like some SodaStream bottles because I was running out. But because I was happy to come to work, but it's part of my routine. It's like, yeah, it's kind of second nature almost. You're right. But don't you think it's nice, Sammy, when someone asks you that question, like your student asks you, why do you do that? And you have to come up with the answer.
Oh yeah, it's part of the learning process too. That's why I think it's good for clinicians to go back to teaching, because you have to reevaluate what you've been doing. And students will ask you that because you want the raw students that are innocently naive to what's going on, so that they ask you those questions, right? That's what you want. You get some students that ask you silly questions, and a silly question to me is one that you already know the answer to. You get students that ask you questions that they already know the answer to, but they're asking the question because they want you to reinforce the answer that they already know, right? Whereas the naive student, the innocently naive student that is really inquisitive about, why are you doing that for, Sammy? Like, why are you doing it that way? You really then have to think about why you're doing it that way, and then your reason, if you've done the right thing, it'll reinforce what you've been doing. And if for whatever reason you've maybe changed the way you do things, it'll take you back to a better way of doing them, or have you reevaluate them. But no, definitely, I agree with you on that point. And so that's been a big learning curve of taking on students, as they constantly challenge you. What I did want to ask you, you mentioned about the video. About the video of you videoing the surgeries. How do you deal with the patients that watch the videos before the surgery? They jump on YouTube and they watch what a knee replacement looks like, or an ACL, and they see the drill going in, and then they freak out. I've heard of that happening. How do you deal with that?
I mean, the patient that's going to watch it beforehand, they'll probably watch it, and if they're going to get freaked out, they'll stop watching it pretty quickly. And then there's the ones that ask you really inquisitive questions about, like, what's this thing and that thing? And that's actually quite fun, because there's that inquisitive person who wants to know more. And they're the ones that get really excited by watching the video. The video is, I don't know how many of my patients watch it, probably not that many when I ask them at 6 weeks, because I show them the still pictures. It's probably less than 50%. A lot of them don't know what to expect, right? So I show them the still pictures and they go, it's not that bad, I'll go and watch it. A lot of them don't understand and they don't care.
I've still got the video of my ACL. I geek out on it.
Yeah, man. But part of that's also like saying to the patient, I've got nothing to hide, right? I want you to have this. This is part of your medical record. I'm gonna video the surgery for you. Like, patients should get their arthroscopy pictures, for example. There should be nothing to hide in that. They should get the video, because there's nothing to hide in that, right? Yeah. If I struggle with something, they can see me struggle with it. Like, yeah. All
right. Look, I want to ask you, now that you're managing at the moment, you're managing North Sydney Orthopaedics and Sports Medicine Centre. I mean, it's not
as glamorous as it sounds, honestly.
I know. I realise that. I totally get it. But, mate, you've got a lot of, I guess, big fish there that you're having to deal with. I mean, what's that been like? From a business point of view, I guess, and from a personality management point of view.
So, it's a big question, right? So, first thing is, we get taught nothing about business when we start as doctors.
We don't either.
Right? Yeah. I had the fortune of having a family that involved in medicine. My mum was a practice manager, so I kind of had some framework to it a little bit. And then I joined Leo in practice, and a lot of those things were already in place. And so I kind of could build upon that. We went through some staff changes. We got amazing, wonderful staff now, right, that do such a good job. And really they help to revolutionise some of those processes going on. So that's within our own practice and how things run. And then I sort of been in practice for a few years, and then taking on this role as the illustrious title of managing partner really means you're just the communicator for the hospital and negotiating leases and things like that. It's an odd experience, right? One, you got to deal with all the personalities. There is people that don't get along in certain things, right? Different staff members, different partners.
Different surgeons, I'm assuming.
Different surgeons, yeah. Someone parks in someone else's spot, stuff like that, right? There's like the negotiating with the hospital, putting yourself forward, talking to CEOs of private hospitals and things, and sometimes I walk to those meetings, I'm like, it's a weird experience. It's definitely character building, though. Right now that I've done a lot of those things, you get to meet a lot more people. It puts your name out there, and you realise that sometimes some people are in the same boat. Right? Everyone's gone through the same experiences. I'm 37 years old, and don't think I'm like I've done a little bit of living already, and so. Realistically, I'm just still learning about all those business aspects.
Yeah, look, the business side of things, the management side of things, the buck stops with you, though. That's the difference. You know, like
it does.
People look at you for the answers. Like, you know, when you're not managing partner, you can kind of just be the surgeon, right? You can be the practitioner. But when you are managing partner and there's an issue, ultimately they go, well, what does Keran think? You know, we need to find out. Keran's got to code this. Keran's got to do this. Keran's got to, and so. You could delegate, and you'll learn how to delegate. You will learn how to delegate. You have to, but ultimately, right? Like it becomes you. It's like for a long time, Leo was the person that really drove North Sydney. Off the back of his reputation and others, but it was also his particular, I guess, gathering of those really good surgeons, Kim Slater and Michael O'Sullivan, and those guys who are really good at what they do. And obviously you're going to have to take that on to your shoulders now.
So I've had to have some of the experiences, right, where you take some of those names you mentioned and then you put them in a room and you have to come up with decisions. I think the first thing my first approach when I took over that role is to just be respectful of everybody. And say, you guys have got years of experience, right? And I asked lots of questions. I sent so many emails, like updating once a month. This is what's happening. This is what's going on. They couldn't have cared less sometimes, right? Oh, thanks for the update, Keran. That's great. And I've learned which bits matter and which bits don't. But I think that was important because it says, hey, I'm willing to and open to listening to you guys. In fact, I had to go into renegotiating a current lease at the hospital, and I said I might call on some of you guys for some backup, and everyone's like, no, you'll be fine. But it had already gone through that process of like gaining trust to be like, yeah, you're allowed, you can do this. You can do this yourself. We don't need to be there for you.
Yeah, good. That's good. All right. And so I guess, have you found your feet there? I mean, how long has it been now since you've been managing that practice?
So I've been in the practice for bit over 3 years now as a partner, and I don't know, this role for.
Have you been managing partner for that long?
No, 6 or 9 months sort of thing. Yeah, and it's fine, right? So I know. You know, the most controversial topic at the moment is Christmas party. So, like, that's fine. Like, I've done a lot of the hard elements start of the year. Good. A lot of those are done and dusted for a while. Yeah.
Yeah, right. Okay. All right. Well, I guess, where can people find you, Keran? Like, if anyone wants to go out and watch you do surgery, or they just want to be in contact with you and kind of, I can leave your email address.
Yeah, I think that's probably best.
I can do that. Is that the best way to contact you?
Yeah. I think you can leave my email address, maybe the admin account as well, and they can reach out to my staff and find a date to come and visit. Yeah, rooms.
Awesome. All right.
Come and visit.
Well, we'll say good night to our public listeners. I want you to just hang on the line with me so I can ask you some questions for my Success in Practice students. But everyone else, thank you to Keran. Thank you for joining me on this episode. And we'll see you on the next episode.
Thanks for having me, Jamie.